We've also gone on to look at mutations as well. So where we have sequenced almost 500 newly diagnosed patients, we can identify mutations in genes. The two most commonly mutated genes are KRAS and NRAS, which are involved in MAP kinase pathway signaling. Rather surprisingly, we didn't find any association with outcome. So patients who do or don't have these mutations, there's no difference in outcome based on current treatments. The KRAS and NRAS mutations are present in about 40% of patients. And what we generally find is that they're also mutually exclusive. So if a patient has an NRAS mutation, they're unlikely to have a KRAS mutation as well. And this is because they're signaling down the same pathway, and so the cell doesn't need to have both abnormalities in them. We also find mutations in TP53, and those are associated with a poor outcome. We also find some associations between the different markers. So we find that patients who have a T414 translocation are also associated with mutations in FGFR3. Patients who have an 1114 translocation may have mutations in cyclin D1 as well. And this is a kind of a biological phenomenon where the translocation in those patients results in mutation of the partner oncogene as well. We see some associations with other adverse markers as well. So obviously, patients or samples where we have a deletion of 17p, they can be associated with mutations in TP53, and samples which have deletion of 13q often have mutations in DIS3. And this is because we're looking there at biallelic inactivation of those genes. So we normally have two copies of a gene in a normal cell, and loss of one is bad, but loss of both can be even worse.